Right. Welcome, everybody. My name is Shihab Romeed. I think I met most of you in the last few weeks, either through my presentations or our guest presentations. It's been a very busy time with the lockdown with coronavirus. I very much hope that things will go back to normality sometime soon. But in the meantime, try to invest in our time as much as we can. Probably most of you know me, I'm a consultant in restorative dentistry at Queen Alexandra Hospital in Portsmouth and also the director of London Dental Academy. And I work in some private practices in London surrounding areas. The topic of today will be full mouth rehabilitation of the fully edentulous patients. So we will talk about the medical and surgical considerations in the rehabilitation of fully edentulous patients. We will talk through some of the data on adult dental health surveys in the UK and also on the life expectancy for our aging population worldwide, based on some research and some surveys done by the WHO. And we will understand through the presentation the challenges we might come across by treating aging population and looking after their oral rehabilitation, and also to get insight into the management trends of the edentulous patients and to explore the impact of aging population on our healthcare system and on our dental treatment in general. And we will discuss some cases in terms of the oral rehabilitation in the light of best available evidence. We will go from the conventional into the more advanced treatment to more complex treatment, I would say. A recent survey or study done by the Lancet, which looked at data between 1990 to 2010, which looked systematically at the burden of aging population in the healthcare systems, and also about the trends of healthy life expectancy. This study was actually a multi-center study published by the Lancet. It was a very comprehensive and big study, which looked at the trends of the public health and aging population in general, looked at the standards of health, and looked at the standards of, or the average of healthy life expectancy across the world. As you can see probably on the map, everything, as you can see in summary, in light blue and a bit darker blue, it's better than other areas which are in yellow, as you can see in red, like in Central Africa. And the healthy life expectancy in these countries in average was in female populations about over 61, and in male populations is 58 years, 0.3. This was in 1990s. However, things improved over time. And the last 20 years till 2010, before the pandemic of coronavirus, we reached up to 70, 75 for the male population and above 80 years of age for the female population. And that could be attributed to the fact that there is advanced medicine nowadays and the healthcare system improved worldwide, let alone the fact that people looking after themselves in terms of diet, lifestyle, and also in terms of daily exercise. So let's look at the UK figures, and this is taken from the Office of National Statistics, and looking at here, we're looking at the disability rather than looking at the healthy life expectancy. So we're looking at the figures from the other way around. So the first, as you can see, graph showing the male individuals and looking at the average of disabled male individuals within society according to their age groups from age, let's say 5 to 80, and likewise as well for the female population. And as you can see, as we get older, the trend of disability increases, and that presents between 10 to 20, 30%. So I would say by the age of 70, 75, we get almost 20% of the population registered, or they could be socially or medically disabled. Likewise, the figures not far in female population, a little bit less, I would say by 5%. If we're looking at age 75 to 80, you will get almost 20%. And if you look at the UK map, you will see, as you can see, the trend of more disabled up north, northeast mainly, Wales, followed by Scotland and Midlands, northwest England, And the least, as you can see in terms of disability, is in Southeast, Southwest England and Ireland. And that, again, that would reflect the number of hospitals, the access to healthcare system, lifestyle, education, and the demographics and the socioeconomic backgrounds for the population in general. Some of the studies actually indicated that the healthy life expectancy rises to up to 64 years of age for men, and more than that for women, which is almost over 70, 72-year-old of age. Again, I mean, this is good rise, especially in England, comparing to the figures presented by the Lancet, which indicated about 58 years of age. Now in England, we probably more than 64, 65, and the women between 70 to 72. But again, still be suffering actually from disability trends in the general population. And that again could be attributed to the fact that there is a problem in terms of lifestyle, lack of exercise, I would say the education about diet and consumption of alcohol, and the diseases as well within society, and obesity as well is quite spread. As you can see, almost 300 million pounds spent a year just on obesity treatments. And of course, with obesity, you will get diabetes and other medical conditions. Now, moving forward, from the dental point of view, as all of you are aware, the late Professor Steele carried out some adult dental health surveys. And what we can see from the first graph here, this presents the number or the percentage of edentulous people within the population. And as you can see, that we have got 5 line graphs between 1968 2009. I will not look in the middle, but I'll look at the blue and the yellow line graph. As you can see, in the age group between 65 and 74, we used to have almost 60 to 70% of the population 50 years ago, or 50 years ago, they are fully edentulous. But looking at the figures 10 years ago, less than 30%. And I say the exact figure nowadays is less than 10% in 2020. If we're looking at the number of people with 21-year teeth or more, and again, we have to compare 1978 to 2009, and then we have got almost 40 years difference. And as you can see in the blue color here, at the age of 55, as you can see, less than 30% they have got 21 teeth or more. But in 2009, if you look at the same age group, 55-year-old, we have got almost 70% of the population they have got more than 21 teeth or more. That will impact, of course, on the quality of life and the dental treatment and the impact on the healthcare systems. Now, we've done some actually local studies in Hampshire looking at the trends of referrals to our local hospital, Queen Alexandra Hospital in Portsmouth. And during the audit, which was carried out about 3 years ago, between 2016 2017, as you know, we have got a quite big catchment area, over 1 million people live in Hampshire, plus Isle of Wight, plus other areas, probably from Surrey, from East Sussex. We would say probably 1.5 million people live in our catchment area, and we serve on a daily basis. We looked at the referral system, and we found that most of our referrals, almost 3/4 of the referrals, coming under the umbrella of prosthodontics. But when we looked in details about what was the prosthodontic, because prosthodontics could be anything, and we found that the most common referral letter coming through the doors from our local GDP practice or practices was due to difficult dentures. It's quite, I would say, daunting from our point of view, and it's quite disappointing as well from that respect, because dentures in dentistry, probably one of the easiest procedures to do, the lowest risk in terms of litigation, and the most enjoyable thing, because probably it's easy procedure to do, the quality of life you provide people with, and the improvement is quite dramatic into people's quality of life. So I'm a bit surprised personally why these trends, why people are referring more dentures to hospitals, to specialists, rather than doing them within their general practice. Is it to do the lack of education? Is it to do with the remuneration system and the UDA system? Or is it to do with training, whether postgrad or undergrad? I think from my point of view, looking at these factors and analyzing the data, I think to do with all these factors together. Probably within the undergraduate, as I used to teach before in Manchester, in London, different hospitals, we used to have limited number of people to treat, and that get even worse and less over time because, of course, the shrinkage and the curtailing number of people presented with fully edentulous arches. But again, this is area need to be looked at and needs to be looked at carefully, especially those people doing their specialist training or people with special interest in prosthodontics, and has to be improved. Otherwise, those people will be left without treatment because most of them can't afford complex and expensive treatment like implants, retained prostheses. And as you can see here, most, as I mentioned, over 75% of population be referred for dentures. Now, looking at this, I picked up this case from one of our referred patients, basically, and on the left-hand side, as you can see, and on the right-hand side to your screen as well, as you can see. So if I may ask all of you guys, is this difficult case to deal with within the primary care sector or as a dentist or as a specialist? Do you need to refer this to a hospital in order to address this problem or to treat this to get better retention for the dentures or better stability? I don't have a straight answer, or I don't have a clear answer to all of you, but probably we can discuss this at the end of the session where we have got time. From my point of view, looking at the technical aspect of it, we have got nice flat palate on the right-hand side. You've got nice U-shaped ridge, as you can see, covered with healthy mucosa, no denture stomatitis. We have got fairly nice size tuberosities with some undercuts on the left-hand side and the right-hand side. A little bit of shallow sulcus on near the buccal frenum or buccal frenum. But again, from my point of view, I think this is a good size ridge, a good size surface for getting nice adhesion and nice fit for the dentures. Not necessarily excellent retention, but I think we can get reasonable stability, and as that's what we do on a daily basis, my colleagues and myself at our unit. Looking at the other case, I selected this case because it might be more challenging, and the challenge here, because as you would know probably if I ask all of you guys, you would say to me, yeah, it's quite difficult because we have got opposing teeth. Indeed, when we have got natural teeth, and as you know, when we have got natural teeth, even more difficult case when you have got only natural teeth between 3 to 3, they call it, what is being called in the literature as combination syndrome, you will end up with a flabby ridge in the anterior region, which is quite difficult sometimes to get retentive dentures. And also you will have more soft tissue, which is really difficult even if you're planning to do some implant work if you want to, especially in the anterior region. Let alone the fact when you have got these teeth on the lower arch or on one arch, the stability of the denture, it would be compromised, and the retention as well might be compromised because these teeth will be, once to come into function, they will straight away, they will work on the anterior region, especially with the guidance and breaking the seal from the posterior region, making it difficult for patients to retain their dentures. And as you can see, early guidance on the anterior teeth will definitely break the seal in the posterior dam zone, and also the vibrating line would be no longer in function in such cases. The other, although it's nice ridge, as you can see, a very nice height, very covered with healthy keratinized mucosa, very stable. Not very big frenum present on the left or the right-hand side, but I can't see undercuts, especially on the left and right tuberosities. That could add to the difficulties. Sometimes you need to be very careful, guys, when it comes to such cases. Don't get, I would say, surprised if you get big ridge and poor retentive dentures. This is quite normal, especially when you've got very flat palate, very big alveolar ridges, but the denture does not stay in place, especially in these cases. So sometimes you've got very small ridge, very small palate, but you get very strong retention, and that due to the fact that either you have got nice retention or you don't have a lot of function or action on the opposing teeth or arch. Now, looking into more details in this case, this is a lady I saw at Guy's Hospital over 10 years ago. She presented with this ridge. To be honest with you, this case won't scare me. When I look at these cases, I will not get scared that much. I will not make any assumptions. To the contrary, I would proceed making standard full dentures, because I know that I will get, at least in these cases, a nice fur stability. And the stability always will be enhanced by the presence of inframylohyoid fossa or fossae on either side, let alone the fact if we get nice support on the buccal shelves or the external oblique line, that would help me to stabilize the dentures. The beauty about these cases, as you can see, the tongue is not that massive, is away from the ridge. Most people coming through the doors when they have got a small ridge resorb to a certain extent, but the tongue is covering the ridge because they haven't worn dentures for a long time, is quite challenging. And you need to be careful about these cases, what you promise your patients, because when you start making impression, you will find it very difficult. The tongue is pushing all the impression material, the trays and stock trays, special trays, and the dentures, of course, will be dislodged immediately once and being fitted. But these cases, I would say, healthy keratinized mucosa is quite nice cases to look at and to treat whenever you find yourself come across these cases. Now, if you look from the outset here, you will see that looking at the corner on the left and right hand side, sometimes you won't get the retention you want or you're looking for, because all what you can see a little bit of undercut. My advice in these cases, you need to get your finger down there. You need to push your impression material, whether it's a primary or secondary impression, but here I would probably be talking about the secondary impression when using the green stick. Has to be warm, really warm, and has to be soft. The viscosity of the material would help it to flow inside the area. If doesn't flow in these areas and does not go and depict all these details, then I think we have to make it flowable in a sense it can capture all the undercuts. What I do normally myself, I try to push my finger in that corner, try to push my green stick material in that part of the impression compound to pick as much as we can undercuts. But, and here big but, please, don't try to do two sides at the same time, otherwise you won't be able to get it out, because having undercuts on either side becomes difficult. So I do one side. If I'm happy, a little on the other side, just to guarantee a good retention. If I'm really happy with one, it's enough for me, because otherwise you will end up with massive trauma on either side, and the patient will, although it's retentive, stable, strong, but the patient will come to you many times in the morning, in the afternoon, and disrupt your schedule because they suffer from pain, discomfort, and trauma. And we look at the denture, you'll find some ulcers in these areas. We've been doing this for over 20 years, and this is quite common, and I think most of you would agree that we need retention, but we do not need to lock the dentures in these undercuts if we can. So one area is enough green stick to be hot to a certain extent, put it in some warm water, get it in, but you need to push the tongue away. If you don't push the tongue away, this material will keep going in different directions, will not flow in this area. So you need a flowable type viscosity in order to get. We don't need to have high viscosity, which is difficult to flow in this area. We don't need low viscosity like most people using silicone. And I want, to be honest, I wish I can talk about this hours and hours. So this is quite important. So we don't need a very, very flowable material like a light body silicone, for example, or medium body silicone, because that will flow straight away, will give you good extension, but will not give you good width in this region. And borders and border molding is about width rather than about extension. I think that could be explained in different sessions, but let's just crack on in more cases. Again, this guy, Jack, I think I saw him back again 2011-12. He had some anterior teeth, as you can see, the alveolar ridge and the palate's quite red, as you can see, and most of you agree that this patient has got denture stomatitis. And most of you agree that this patient most likely is wearing the denture during the night. And we always recommend the patients to take dentures at night, not to wear them when they can, in order to avoid such problems. So the first thing to start with, we need to rule out any fungal infection, any underlying medical conditions, and we need to make sure that the patient is working with us, engaged in the process, because this is a process. 6 appointments in the best case scenario is not that straightforward, so we need to make sure that the patient compliance is great, able to listen, to take the advice. If most patients are a bit old, we need to probably to exercise a bit patience and to take into consideration their age, their understanding. And we work with the patient and their carers in order to make sure our treatment is successful. I think most of the problems we come across treating such people is the fact that our patients, either they don't comprehend or they don't keep the information, don't retain the information due to the dementia or another memory loss. And physically as well, they might have some Parkinson's, and we treat a lot of patients like this in our unit. It's quite challenging, quite difficult, but at the same time, it's quite rewarding and enjoyable. So I would say, please, by looking at these cases, make sure that you have enough patience with your patients, and also take into the consideration how would they react and interact with you during the treatment. Now, looking at the impression on the right-hand side, this is a zinc oxide impression material, which is, as you can see, nicely border molded with, I think, green stick, and I took the impression with zinc oxide eugenol in a special tray. This is the standard, nothing new about it. I think most of you agree that it's important to do such treatments in standard way. On the other side, for example, when we look at the posterior dam zone here in this area, you will see that is overextended. But this is not the time where we will go and treat our people in a way to, I would say, saying that, okay, we have to cut it, we have to trim it. No, leave it, cast the model, you come back again, and then on the model you will score your, I would say, the vibrating line or the posterior dam zone. We have got most of the retention. So you need to be a little bit careful when we doing such treatment. Casting the models, as you can see, upper and lower, we have got nice ridges. As you can see, massive tuberosity on the right and left-hand sides. And this is the area, you can see when you finish, almost 2 millimeters of the fovea palatini, and also behind the homular notches. Keep it extended to the homular notch. Don't underextend it. I know it's massive, but I keep it that way is much better rather than underextend it. So I try to get the best extension possible rather than extend the early stage. I would not advise my technician to cut or to adjust the model at any stage at all. To the contrary, I want them to keep the model as they are in the impression, and then we deal with that at later stage. The lower model even looks nice, and beading boxing always is recommended, as you can see. And the key area here, the back or the posterior, we call it retromolar pad, and we need to make sure it's really extended to the 2/3 of the retromolar pad. I'll keep it full in the beginning, but I would say at minimum 2/3 of the retromolar pad. This is the very, very important in terms of retention. If you cut it here, the denture will not stay, let alone the fact that will give you very nice support along with the external oblique line or the buccal shelf. And the ridge, as you can see, is not very retentive, but you have got nice ridge, good support, and nice keratinized mucosa. When you say, well, can you see the keratinized mucosa? Yes, I can see on the model. When I see, can you see that ridge? Almost most of the time, you will have nice, if you don't have any sort of flabby or some indentation, then it must be stable mucosa out rather than anything else. So you need to be a little bit careful when we design our dentures or our models. Now the trick, and here I don't want to go into further details into this subject. When you do your dentures, I will ask my denture to have the base plates into a clear heat-cured acrylic. And that at this stage of taking the bite, I will get stable base plates. I can take the bite clearly, and I'll have early information about the stability and the denture. So I don't want to leave it late in the process in order to get the information I want about my stability and retention. And if I need to do any changes at any stage, I can do that straight away. Now, let's presume that I finished my denture and I'm in the process of doing, I would say, either the bite or finish the bite, finish the try-in, and fitting the denture. Now, I did this example, and this is the edentulous surface or tissue surface of the new denture comparing to the old denture, and this is the occlusal surface of the new denture comparing to the old denture. Clearly, as you can see, there is a big difference, and the difference, as you can, most of you will agree, that is to do with the extension. The size of the lower denture almost double the size of the old denture. And likewise, in the new denture, as you can see, if you look at the inframylohyoid foci on the either side, you'll find the extension exactly what we want it to be, because that's the way it should be. It should be fully extended, and that will give me good stability and retention at the same time. And support, don't forget, the more surface area you cover, the better the support you will get in general. So that will give you very, very stable and nicely designed dentures. On the lower arch, as you can see, the only, I would say, probably this is one of my trainees made this denture. The only, I would say, thing which I wouldn't do in such cases is the sevens. I never set up the sevens in the upper or lower dentures. I always keep it shortened to the 6 and sometimes to the 5 if the patient has the patients have very limited mouth opening, cancer patients, or the patient is quite old, frail, or even implant, bridge, or overdenture. So I would say 80–90% of the cases till the 6, and I would say 10% to the 5. It depends on the cases. By the way, the functionality of the denture will not be affected by the number of teeth. If you get the 6 there, and this is the Kaiser studies on short dental arch, you will get almost 80% of the oral functions. To the 5 will give you at least 60% of the oral functions. So there is no harm under extending or shortening the arch to the 6 or the 5. I would say 6 is the gold standard across the board in all my practices. Looking at the upper denture, as you can see, probably the same patient. This is the old and this is the new. As you can see, this is the old and this is the new. The extension, again, this is a clear base with pink acrylic, blended very nicely. There is no problem as such. And as you can see, the extension is much better. The borders being molded, and as you can see, nicely rolled, and that will give you very good seal and retention subsequently. As you can see, very thin borders. As I mentioned before, as a matter of a fact, is always the borders, they should be rolled and wide as much as we can, because the border molding is to do with the width rather than the depth. The depth is good, but I don't want it to be overextended, because that will reduce the retention of the denture. But look at the texture as well. Very beautiful texture of your gums as well, of the pink acrylic in this area comparing this. This is quite dull, quite artificial, and the patient not necessarily will enjoy what we're doing. So we need to be careful of the art of the dentures as well. The dentures are not only, I would say, artificial teeth. There is a static element of it. People sometimes coming to you with early stages, in their 50s or even sometimes 40s, fully dentures. So we need to respect the fact that they need pleasant, nice smile. They want to go to socialize, to go with the having meals with their friends, with their families, to get a day out. And some of them, even the social elements are far more important than the functional element. As long as they have got happy and nice smile, they wouldn't mind even if they're struggling a little bit with the dentures. So please bear in mind that the aesthetic in terms of shade and shape selection, normally I do that with my technician all the time to make sure that we get the best treatment outcome. This is probably the last slide. I will not go further. As you can see, this is probably a better denture. As you can see, double the size in terms of extension to the 6s in this area. And the extension, as you can see in this area, is quite nice into inframylohyoid fossa. That will give you nice retention and stability. I spend good time on explaining to you the full dentures and the principles of that, because this is the base for implant overdentures. I'm saying this because, in fact, this is key if you are planning to do some implant work, if you are planning to, whether implant overdenture or implant bridge, and especially with implants, I would say overdentures. Don't try even to attempt to do implant overdenture if you don't get to this stage, to this quality, because you will fail, and you will fail miserably. So therefore, please make sure you understand the principles very well. Patients is aware of that. Never start implant treatments unless you have got the baseline right, which is acceptable dentures, except probably the fact that dentures are not retentive. So if the dentures are not retentive, then yes, there is a case of, I would say, going for implants, but don't try to go straight away to the implants, because the implants will be either the wrong position, will not help the patients, and the patient will come to you with the same problems, complaining of lack of retention, complaining of the denture being causing some problems and pain discomfort. But if you get 80, 90%, even 60% right within these conventional mechanisms and techniques and tools, then the implants will enhance your success rate and will make difference into the patient's life, justify the cost which you will ask the patients at the end of the treatment. As I mentioned before, the smile line should be looked at. Never go for, especially with ladies, never go with low smile line, right? With ladies, against, unlike men, ladies show more than, I would say, half of their top teeth to 3/4. Men will show more of the lower teeth. It's quite opposite. So with ladies, you need to make sure the smile line is average to high. And that's why I normally attempt on my most wax-up trials. If you get it lower, the patient will not see the teeth. And that might indicate as well, unfortunately, the fact that you might have lack of interarch space, meaning that you have got a problem with your OPD. So try to get the best you can from your, I would say, wax trying. Agree everything and ask the patient, do you need anything more? Are you happy with the denture? If not, then there is a problem, and we have to, don't rush it. And most people, unfortunately, especially our young colleagues, and frustrated with the appointments and all of that, they try to rush into finishing. Never finish the denture unless the patient and the partners or the companions of the patients are happy and they know what they're doing. So spend some time, is investment rather than wasting your time. Lip support. I think I don't want to overemphasize the importance of lip support, but again, looking at the profile of the patient, if it's very and young patient, recent extraction or dental clearances, you will always, most of the time, you will end up with bulky and over supported lip. And in this case, probably we will go for something flangeless dentures. So you would have gum-fitted teeth rather than with a flange, because you spend hours and hours trimming the denture, bring it back in order to get the lip support right, but you won't be able to get it. So my advice in this respect, get the wax trying as early as possible. And look at, as you can see, the, I would say the teeth are in very good position. Now, sorry, just I think I opened the other camera here. Let me just close it. I think now started. Yeah, so now looking at the upper dentures, and here we probably the final checks which we need to do is the occlusion. And I'm talking about, not talking the OVD, I'm not talking about the bite, about the occlusion itself and the mechanism of the occlusion, because it's quite important to understand that the occlusion and refining the occlusion is quite important. By the way, whatever checks you do in the wax train is not going to be as good as when you deliver the dentures and you do the final checks or the fine tuning of the dentures when you do the checking the occlusion. As you know, I don't want to go into occlusion. This is not occlusion lecture, but as a matter of principle, you need to have mutually supported occlusion. Balanced occlusion, only one case is when you have got full mouth rehabilitation, which meaning full denture is one of them. So you can see on the lower arch, these are the old dentures, no contacts, mechanical occlusion. Basically, we have got flat surface against flat surface. So we don't have cusps, we don't have any mechanism of interaction or intercuspation between the teeth. So you won't have necessarily any sort of engagement or guidance, or I would say even working on worker sides. But if you look at the other side here, that's what we're looking for. Posterior contact in all teeth, as you can see, mutual support posteriorly, and every single tooth is engaged. If it's not engaged, we need to get it into occlusion from 4 to 5 to 6 to 7. The second thing here with balanced occlusion, any anterior guidance should not at all adhere, and probably this is personal opinion and this is through experience, you should never ever engage the anterior teeth early into the process. If you engage the anterior teeth in the guidance, and if you want to ask later at the webinar, please do ask. But just to make you aware, you have to have space into the ICP, RCP position between upper and lower anterior teeth, and that do it across the board, even with implants. So make sure you have got a little bit of gap and space there. When we get into action, then the engagement of the posterior teeth will help the anterior teeth, but at the same time reducing the risk of breaking the posterior support or the posterior seal. If you have it early engaged, what's going to happen? You're pushing the upper teeth, especially from the palatal surface, forward and breaking the contact on the posterior, meaning that you will end up with breaking the seal and lack of retention. And that's most of the dentures. Most of the dentures, you have got either contact on the canines or the palatal surface of the centrals, most of the dentures. So having two, three small tweaks in the denture might improve your retention dramatically, and the patient will feel the difference. So please make sure you will pay some attention. A lot of studies, a lot of books, a lot of textbooks, but the most important is the patient, and each patient is different, each denture is different. Look at this denture here, for example. Where's the curve of SPE? Where's the occlusal scheme? Where's the position of the teeth? The arch is going the other way, that way is concave, and the upper convex. We haven't respected anything, flat surface. Don't expect this patient will function normally. The patient will struggle, will come back to you over and over and over asking for better dentures. These dentures are not amendable. When I look at these dentures straight away, I would say, sorry to say that, these are not fit for purpose. These are not meant for you. We need to have something better fitted, as you can see, the curve of SPE, the occlusion, and the occlusal contacts all in place, the anterior teeth, as you can see, and as you can see, the curvature of the teeth and the tuberosities, along with the inframolar height, was the buccal shelves, all coming into action in order to give us nicely designed and nicely, I would say, finished dentures. So we need to be careful when we design. So going back on this case, it's class 5 on ADSUS classification, depressed, not very severely depressed, but there's almost nothing there. You will do good dentures, but I think in these cases, one of the requirements is to have good retention for the denture. Therefore, we need probably some aids for our retention. Now, all of you guys, you might have heard about the consensus statements by McGill group, which was, I think, echoed by the British Society of Prosthetic Dentistry, that the minimum standards of care was called the York Consensus Statement on Implant-Supported Dentures, published in the European Journal of Prosthodontic Restorative Dentistry back 2010. And McGill statement or consensus as well was published 2002. So the minimum standards of care is having 2 implants on the anterior region, and any type of mechanism of retention is yours. I will go through it and I will try to highlight what it's why is important to have such type of retention or other type of mechanisms like the locator abutments, because locator abutments is quite good in terms of the maintenance, in terms of retention, in terms of troubleshooting as well in the future, and the mechanical complications might happen. For those of you who doing locator abutments, as you know, quite simple, straightforward. It doesn't need to have any sort of special arrangements. You have got, we call them the locator pickups. They are a closed tray type of pickups. Some of them, as you can see, come in different shape. We have got 2, 3 now in the market, but most of them, they're coming from Zest Anchor, is American company, which doing basically the same, I would say, replica or the same shape for all implant systems. I never come across implant system doesn't have a locator, but now some other companies like Noble Biocare, they start producing their own locators, and also Straumann, I think they call it Novaloc locators. The reason I want you to stay away from the more specified to more generic is because of the patient's maintenance. If you treat some people and you are not available in the practice, or they move somewhere else, there is access to different or interchangeable components. So keep it standard if you can. So wherever you go, if I've got a patient, some patients coming through the doors, I can amend, I can repair and troubleshoot the denture on the same day, on the consultation day, either changing the insert or changing the abutment, or probably changing the size of the abutment. It depends on the case. So try not to complicate things for yourselves and for your patient, rather having a standard system to use in your practice. So you're picking up the, as you can see, closed tray technique. This is the upper denture. See how lovely the material will flow, the viscosity, the flowability of the material, the border molding. I would know for sure this patient, I would say 90% they will get good retention. I don't think in these cases you would even need implants. And to be honest with you, even because here in these cases, picking up and look at the border molding, look at the impression and the ridge, I think this is a different patient from the one we saw for the locators. This patient, I would treat them without implants happily and confidently and predictably, because I know these people will have good retention at the end of the day. So let's move. We are spending a lot of time on these things, but I'd like to highlight these people coming through the doors with these dentures, and we call them the inserts. And we have got metal housing, which has been acrylic processed during the plasking stage, and never put them in cold unless you are happy with the dentures, and probably explain that in details later technically. If you've got dentures nicely processed, happy with them, you can add them on like a church side by cold acrylic, but send it to the lab for finishing polishing at the end. You don't get weak link or bonding. Now, most people coming after 6 months to 12 months complaining of loose dentures, and the reason behind it, the insert has been damaged or worn down. These are at the end of like peak material, doesn't stay forever. So we need to make sure these are, we have got enough in the stock to change them. Now, again, one of the problems I might face, or I normally face, that dentists send them back saying, I don't have the tools to change the inserts. If I ask you, what are the tools? You tell the locator, removal kit, and there are 2, 3, it costs me a few £100. I see 1 or 2 patients a year. I don't think is worth for investment. So just I want to show you something I use on a regular basis. This called the, probably all of you know, is the magic tool or the instrument in any dental practice is dental probe. As you can see, that's all what I use for changing the inserts. So the sharp part is to engage. Normally, if you want to engage it, heat a little bit and then get engaged and flick it out, you can remove the insert. And to put the new insert back using the back of the instrument and push it as you would push anything inside the housing, and that will push straight away almost the same standard size. If you've got amalgam carrier, you probably even better. Pick up the amalgam carrier from this, as you can see, trench, and put it inside the insert or the housing, and that will fit nicely. I don't have videos on this, but probably I will show it to you at some stage where you can practice this, and you'll find it very, very easy. It doesn't need all what you need just to keep in stock these cheap inserts in different colors, again, from clear, pink, blue, green, and I think black, which are the lab-based inserts. And this is the overdenture finished. Again, as you mentioned, it's nice, lovely in intercuspation. The interdigitation between the teeth, lovely, is nice. If you look at all teeth from 6 to 6, all in action, apart from the anterior teeth in the ICP, RCP position, I will leave some space. So when you look from this corner, from that perspective, you will see a light coming through. So I don't want the teeth to be engaged 100%, but rather having at least 1 to 1.5 millimeter separation. So when you start the patient, the action in terms of the guidance, anterior guidance, then the upper denture will come late into action, reducing the possibility of having a break of posterior, the seal of the posterior region of the posterior dam zone. Look at the gums, as you can see, very nice, very subtle vascularization of the pink acrylic, as you can see, mimicking the gums as much as we can. Sometimes even you can change the shade due to the racial pigmentation. You can have some darker or lighter. I've got 5 shades in my lab, so I can change whatever I want. And the teeth, don't get cheap teeth, please. Invest in the teeth, not that expensive. Some companies like Predent, they do very nice, lovely HPP, high performance polymers. Use the nice teeth, and that is investment for you. Then you don't want them to wear down quickly. You want them very aesthetically nice. You will see some cases in the webinar. Another lady, I think, was referred to me from Royal London, was treated 35 years ago, and she had these lovely, nice ball attachment. I think it's very good treatment, nicely placed implants, as you can see, straight, parallel, but the denture was, as we'd imagine, is loose. And the reason, because the ball attachments worn down. Therefore, you have got 2 options here. Option A, either to change the ball attachment into new ball attachments, and that will make it easy for you. But again, you have to change the denture, or changing this into something else. And you've got many options. I would not discuss anything now because I think it's quite limited time. So what I decided to do is just go simple solution, having them change into locator abutments. I did not make them that high for many reasons, mainly to accommodate the space, reduce the fracture possibility in the area, and also many other reasons, which I would just limit my time. Try to get 2 to 3 millimeters supragingival, that would be sufficient. Don't get them long, don't get them short though, the locator abutments. And then you start picking up these impression by close tray technique as usual. So you don't need to have any sort of complication here or anything like that. It's straightforward, and you will, I would say, that would help you to have a special tray. You can use stock tray, but I would have one before changing them. I would have impression with alginate, and then the alginate will help me to say, well, what should we do? What material can use? Normally, I use Imprigum with closed tray technique in order to improve the retention of the pickup of these 2 pickups. Would normally come nicely, easy, without any problem. You can use silicone if you want, but I wouldn't recommend using zinc oxide eugenol, because I don't think they will be picked up, because you need something stiff material in the middle in order to be picked up. And these, as you can see, the dentures, the old and the new one. Probably, had I done this denture without the implants, as you can see, very nice retention. You will get better retention, better stability, better functionality of the denture. As you can see, almost double the size. Border extension is quite good. So, but having implants in place always is, I think, as a bonus for the patient, enhancement for your treatment outcome. And again, I think I took this picture just to show you not only the smile line, which is quite important, this lady, to show that the minimum 1/2 to 2/3 of the teeth. You don't get them any shorter, otherwise you've got a problem either with the OVD, or you have got a problem with your the inter arch space. Either way, make sure you have got nice, lovely midline, nice smile lip support, and as you can see, try to reduce the anterior guidance as much as you can, not only at the vertical, but also in the horizontal area as well. So sometimes you come across cases where you have got thick, soft tissues. And again, here, just to let you know that sometimes if you remove the abutments or the healing abutments, you will find yourself in very difficult situation. So probably the locator abutments can be maximum 5 millimeters, but sometimes you need 7, 8 millimeters, 9 millimeters. Then you need to change the strategy. If you don't have the locator abutments, what are you going to do? What other options do you have? Well, I think in these cases, I normally tend to use different tools, different mechanisms, and probably my first go-to approach is to have a what we call it using two uni abutments, and then on these uni abutments, I will go for a bar, for example. So in this case, as you can see, healing abutments, I think coming from old Astra system, probably 7 millimeters. Even with 5, 6 millimeter, locator abutments might not be sufficient because you need nice supragingival height. So what we need to do, having two uni abutments at the maximum height, as you can see, 5, 6 millimeter, whatever you get in the market. And then on the top of that, you do your superstructure, which in this case, of course, you have to link them. There is no other option. You can't get locator abutments or ball attachments without having both the engaged. So my go-to approach, as you can see here, simple, straightforward cast post. I think it's cast or semi-cast because it's cast. Is the older bar, I think, is coming in plastic, cast in gold. You fit it on the top, easy, simple, straightforward. Nowadays we have got all in CAD/CAM. This is a long time ago being done. So, but you need to make sure that when you do your cases, please make sure you don't do blown cantilevers. Again, this is biomechanically is not acceptable. And then the inserts, as you can see, single insert sitting on the top of the bar. Same principle apply in terms of occlusion, aesthetics, and all the above. Now we're coming more advanced cases. We spend good time, almost 50 minutes. So hopefully we'll spend another 20 to 30 minutes on discussing a few cases. This is a hypodontia case, as you can see in the upper arch, lower arch, no teeth at all in the lower arch. This patient had 4 implants done on the lower arch back 1990s. It came to be with loose overdenture. And he asked me if I can give him better denture. When I looked at the case, I found the bar is quite old. The upper denture is quite old, as you can see. And these very lovely, nice abutments from Brennemark, they call them flat top abutments. I'm not sure some of you worked on them, but you used to use them a lot in the past. I like them. The new ones, a little bit more, I think, better in terms of the engagement because this is a flat top. And it's quite difficult to locate the denture on the top or the bridge. By the way, this is a lower bar and there's implant overdenture on the top. So I decided to design everything to start from scratch. So as you can see, dentures or the multi-unit level abutment impression, and I took it with special tray using a embry gum. As you can see, it's not great details here. In these cases, I might not tend to go, but I can improve it should I want to. But the most important thing, the position of the implants, right? And then this is the old, as you can see, bar. It's quite worn down, and this is called sleeve, which is cast as well. So we need to make sure that the contact between the bar and the is quite good. So moving forward, that time we did not have CAD/CAM. So I decided to go for a new, and the new system which I use, or I decided to do, is we call it locator bar. So we have a gold bar with 3 locator abutments fitted on the top of the bar, as you can see, and very nice fit, although it's cast, but is nice fit. You need to be careful the bar is not chunky, otherwise will undermine the structure of the dentures, will undermine the fit of the denture as well. And this is the fit or the final product, as you can see, implant overdenture with the 3 locators, and these are the black, we call them the lap inserts. And as you can see, I sealed all the implants screw holes with some silicone materials. You can seal it with something else. It's up to you, whatever you want to do, but just make sure that these locators and the denture in a passive position, because otherwise, if you don't have that, you will end up with a problem with the bar, with the implants, a lot of stresses on your implants. The upper, I think I decided to change the approach fully by having, as you can see, even I would say the approach is quite different. So therefore, I decided to go cover all existing teeth. And by covering all existing teeth I think is good in a sense. I can reorganize my occlusion and make sure that the balanced occlusion, which I'm looking for in full dentures, is applicable, although it is a partially dentate arch, but still I can go for something better. And that's why I would say most cases is better to do as much as you can these cases like complete coverage of the existing teeth, because that will give me balanced occlusion, better retention, better occlusal scheme, and better aesthetics as well in terms of the smile, in terms of the coverage, and also how much the smile line. As you can see, all teeth on the upper arch covered. I kept few clasps, a bit complex work, but I think this is good for the future. If the patient has got loose denture, then we can activate it at some stage. These inserts could be changed. Look at the occlusive scheme, 6 to 6, upper and lower. Very nice, lovely occlusion, simple, straightforward. And that will give the patient another 10, 15 years. By the way, this patient came to me and telling me that his partner and his daughter don't know that he's wearing dentures, meaning that they don't take it off. So if I revisit this case again, I would probably do implant bridge on the lower arch rather than implant overdenture. But again, I mean, these are quite optional. I might increase the number, which we will see some cases a little bit, but 4 will give you nice, I would say 4 to 4 probably, rather than going, or 5 to 5 maximum rather than to 6s, and give you better stability. On the upper arch, I might change my views a little bit. The teeth might not be the greatest, but probably a couple of implants and give you implant bridge that would enhance. But again, remember, these cases have been done almost 30 years ago. Things changed and moved significantly in the last 10, 15 years. And this is the denture. As you can see, shallow guidance on the upper anterior teeth, nice engagement of the teeth in the posterior, nice contacts, no problem whatsoever. Now, we talked about the McGill consensus. I don't want to go over that again, but once it's accepted that the 2 implant overdenture is not the gold standard, however, is the minimum standard of care. That should be sufficient for most people, take into account performance, patient satisfaction, and quality of life. So it's when you come to funding and people discussing with you whether we can do it or not, or whether it's public funding or private funding, I think this is the minimum nowadays for the 20th century to have some people, to have some treatment, including 2 implants. Now, I'll discuss with you this case. A lady, I think Italian lady, presented with Sjogren syndrome, cervical caries, being restored at the dentist, very severe dry mouth. Dentures in such cases is difficult, I would say. It's really difficult. It's not that I think easy to deal with these cases. So what we can do for such patients? Well, I think we have got many options, either lower denture, upper 2 bridges, upper partial denture. My approach was a little bit drastic, I would say, but I think that's what we discussed, and that we found that dental clearance, upper and lower denture. And that's why I talked about in the beginning of the talk that we need to remove the flange in order to get better lip support. And these are gum-fitted immediate denture. But it's not too bad for immediate denture. Good retention, good aesthetics, I think. Engagement is good. Occlusion is all right for full dentures. So I would not mind full clearance and such quality and weight in these cases. As you can see, the bone is quite healthy, it's big, ridge. It's almost like I would say class 4 to the classification, so it's nice. So I decided to do this. This is a lady who is, I think, was in her late 70s. So now I'm not going for all in 4, and not isn't intended to talk about 4 and 4 in these cases, but rather to put a plan. You don't need I mean, you look at the life expectancy of the patient, you look at the functionality of the patient, lifestyle, what sort of diet. If I give the patient a restoration would last another 20 years, I think it's good. So you don't need 6 implants in these cases in particular, 4 implants in the position of the laterals, first premolars. When you open the flap, you need big flap. You need to identify clearly the mental foramen, and those who are doing surgically trained, those never ever try to place implants without seeing the mental foramen. It's just computerized, and guided surgery is not enough in these cases. Please make sure that when you do these cases, either you have got somebody with you, and if you are not trained to do it, don't do it. Don't bother to do it, because the risk is quite high. You never know with the CBCT is not necessarily accurate. You've got looping of the mental foramen, the ID nerve. I would love to visualize it. I'd like to see what's going on before placing especially with the 6 implants, more complex cases, severe cases. I mean, this is standard case, but we treated people in 80s and 90s. So we know exactly what we're signing up for. 4 implants, as you can see, relieving incision in the midline, 4 implants, extra implants, and then submerged. And the latest stage, can you see the patient even can't brush? A lot of calculus around the healing abutments. And then standard impressions, always I use open tray, never use closed tray unless some conditions, especially limited mouth opening. Nicely positioned implants on the upper and lower arches. The standard treatment here, again, you have to start with verification jigs. You might ask what sort of materials. I think we will go through that probably at a later stage. And then these are the multi-units or unit abutments for the definitive. I would fit them as early as possible rather than put them at later stage, because that will cost you more money, more time for the patient, because if you change them later, it becomes more difficult. And these are, we call them the prototype for the definitive bridges. And the prototype is quite important here to do before doing CAD/CAM bridges. That will give you a blueprint, and you need to cut them back, and then you do your CAD/CAM frameworks or beams, and then you do the veneering layer on the top. Sometimes I do provisional first, and this is, as you can see, we call it the framework, which is the definitive, this cobalt chrome framework. And what we can see on the top is not composite, is not acrylic, is HPP from Redent. It's very nice, strong material. It's as good as ceramic, and it's easy to maintain, easy to repair. They last quite long, not that expensive. And there is plenty of material in the market with HPP. Please try to use them. The shock absorbing material, very gentle, and it's not easy to adjust if we need to. As you can see, fitted, lovely, nice fit, top and lower. The gums healthy around the implants. If I revisit this again, I would probably create a little bit. It's very, very cosmetic, very aesthetic results, I would say. But nowadays, I try to create a little bit of space, further space. There was space, it's not visible, but I would create a bit further space, especially in this area between the implants and the area there, just to get my TP brushes through and make sure the patient can, especially with the elderly people. It's very nice smile, midline is good, upper and lower, and again, the post-op, as you can see, 4 implants straight, all in place in situ, and this is post-op, as you can see. I think this is a more advanced case, mandibular resection, done due to cancer, floor of the mouth, and as you can see, from angle to angle, reconstructed with 2 DCIA flaps. And as you can see, there is a big space, and we're expecting this to heal within 6 to 12 months' time, but we can't do anything at the early stages because we don't want to overload this load-bearing plate. As I promised you, now I'm crossing 1 hour, 10 minutes, but I try to finish as early. I might break it into another webinar because I might take some questions. And just discuss this case only, and then we close the webinar. I did some, I would say, planning for this case prior to the placement. I thought that I can do it without having big flap again. The patients had many surgeries in the past. People coming through the door, especially with cancer surgeries, they get fed up from the hospital appointments, admissions, and surgeries. So I designed my full denture. I scanned the denture, scanned the ridge, and I sent it to Atlantis in order to get my surgical stent. As you can see, I was planning to do 6 implants fixed with 6 screws. Lovely, nice positioning of the screws. As you can see, the holes, as always is the case with guided surgery. I've got enough bone. The quality of bone is D4. It's not great bone quality, but then we have to accept it because DCIA. And that's the reason I put 6 implants. In 5 years, get 5, and then 5 years, get 4 or 3. It's still, I've got some a full back plan to fall on if they want to. This is the floor of the mouth. As you can see, very, very severe result. Nothing at all on the floor of the mouth. No normal anatomy, as you can see, and was complaining about the frenum, the patient, more than anything else. A flat, completely ridge, no keratinized mucosa, and this is one of the challenges we might face. So I decided to say, okay, let me start with the guided surgery. I said, okay, I put the stent, I fixed the stent with the screws and start drilling. I felt I'm going through the air. Basically, I'm not quite sure the bone or outside the bone. So it's the quality of the bone is quite big, rich. But then decided, well, I'll take it off and then open the whole area. When I opened the area, I did these osteotomies by freehand. I put back again the stent to see where is the difference between this guided and non-guided. And I think, look what I found. The first side of the implants almost on the lingual surface. Look at the other side, almost on the buccal surface. Look at the third side, almost on the lingual side. Basically, like 50% of the implants were not the position where I wanted to be. The take-home message here is don't trust guided surgical guides in fully edentulous case, especially on severe resolved. You trust them in dentate patients, partially dentate patients, tooth fitted. With gum fitted, please try to avoid them at least for this stage, because you never know how is the position. Even with full dentures we use them as a guide, always is hit and miss, but at least we know that we are within the prosthetic envelope and then we open a flap. So if you want to use them, you need still to open a flap at the end and look at the implant sites. Now, the other challenge is I did basically a frenectomy at the same time. Patient was more than happy than probably my implants and the big surgery I did for him, because he can move his tongue after he can talk better. But look at the soft tissues. When you look at the first instance, you say, oh my God, what's going on? Even the surgeon who did the mandibular section told me there is a bit of periimplantitis and inflammation. But that's normally what you get around implants, especially when you don't have keratinized mucosa. So you have got here a few mechanisms in order to push back, either putting some pressure or you harvest some connective tissue or pre-gingival grafts from the palate. These cases, you have got 6 implants. How much you can harvest is very difficult. So I decided to push back and put some pressure. So I started, as you can see now, the other issue, soft tissue thickness. Can you see from there, almost the size of the implant. So I decided to go for multi-uni or uni abutment and healing abutment on the top in order to push the soft tissues back and to get not to do stage 2 or every time I see the patient. So it's quite important to manage the soft tissues. And then when I did the provisional bridge, I scored the model and make sure that there's a lot of pressure on the soft tissues. As you can see, these are multi-int and this is the provisional bridge of acrylic, in order to enhance the quality of the soft tissue and also get ready for the definitive. This is the partial denture on the upper, and this is the lower bridge, the final one. As you can see, the metal, I will show you the x-ray in a minute. The soft tissue is completely retracted and completely, I would say, shrank to a position where I want it to be, and not covering my fixture head or my abutment heads, and the cleaning is possible under this denture, as you can see. And this is the post-op reconstruction, I would say the flaps being connected together and the top and the bottom. So it's quite reconstruction by having this I would say, lateral type of splinting. So splinting the implants, always good for multiple implants. I think I'm afraid I have to stop here as the presentation is going on, and I very much hope that we can do another webinar. I'm not quite sure when, but hopefully at some stage when we are ready for it, to discuss the full arch or full mouth rehabilitation with probably more, I would say, implant retained bridges. Look at the periimplantitis complication, biological, mechanical complication number, optimization of implants, and looking at more sophisticated CAD/CAM structures on the top. And then I decided, as also I did some, actually put some cases together for you from different elements, fixed, removal, number of implants, which one is which, and how, what are the indications, what are the guidelines, and also some complication along with sinus lifting. So thank you very much for your listening and for watching and for your time. It's a bit late, so I will end the session here. And if you've got any questions, I'm more than happy to answer any questions you might have. Let me have a look at the, I've got a couple of questions here. One question coming from, if somebody wants to, I will open the mic as well for all of you guys. Please, if you keep it the background silent. Good. So while I'm looking at the written questions, if anybody wants to add anything or to comment on anything, please let me know. Right. A question coming here. How and let me just how to remove the I have to close one of these mics. I'll close this one. Yes, the question here, how to remove the old retentive rubber from inside the locator. I think I talked to about this within the context of the webinar. The second question, what's your thought on the new locator TFX? I talked about it. There are 2-3 types in the market from, I think TFX, I think used by Noble Biocare. There is Novolog. And so the most widely used one is the Zest anchor locator, which are, as mentioned, standard in size, applicable to every single case. So in a practice, I don't think you'll have a problem with using these locators. The TFX and Novolog coming, the head is smaller, might be useful for the new CAD/CAM bars. It's more complicated stuff. But I think don't make it complex. Go for the standard, and that would help your patient because people might go to different practice or different place, and it's easy to change, easy to find the identical. I always be concerned and worried when I do anything with the patient, any procedure, that are we able to find the same components in 10, 15, 30 years? I'll show you some cases. I saw cases 30, 40 years ago. So always have the backup plan for your patients. Another question, the new denture looks way better than the old, but sometimes patient complains about the bigger size of the new denture. Yes, I agree with you. So don't make it big, don't make it small, just make it the right size for the patient. If the fit is not great, then 2 implants will help. If 2 implants not satisfactory, then the patients have to pay more. Do you take impressions on the multi-units? Yes, I do. But I don't do it on here. We're talking about implant overdentures. In some cases, if we need to use bars or splint implants. Thank you very much, and really nice presentation. Thanks. Thank you. A great presentation. Thank you very much. Thank you, Tramido. Very comprehensive presentation. And last question coming. Please cover 1 or more implant complication. I think that we can do that in the future. Do you use the same occlusal scheme on conventional and overdentures? Yes, the answer is yes. We use it on implant overdentures and conventional dentures because they are the same. So there is no difference at all. Okay, thank you very much, guys, for putting the time at this difficult time. And for those observing Ramadan tomorrow, Ramadan Mubarak, Ramadan Kareem, and hopefully we'll see you sometime soon. I think we're doing another webinar next week. So if you just watch the news, and hopefully on Facebook, Instagram, on WhatsApp as well, we will keep you updated. Thank you very much, guys, and have a nice evening.